Just to go slow about it, and if you have any questions, just let me know. And I'm going to be using a lot of drawings in here, so bear with me with my handwriting on this vertical screen. And then you guys can tell me if I should be more on the PowerPoint versus on my handwritten stuff, okay? Should we get started? Okay. All right, so hyponatremia. So what we're going to talk about is discuss the underlying pathophysiology, then stepwise approach to hyponatremia. We'll talk about common causes, then what is the difference between acute versus chronic hyponatremia, and discuss the management and treatment options. This will not be in the same order as written, but I'll try to cover everything in the next 50 minutes. All right, so my first question is, anyone can, raise their hand or whatever. So how do you define hyponatremia? Is it too little sodium? Yes, no? No. Is it too much sodium? No. Is it too little water? No. Is it too much water? Good. So technically, by definition, we're saying that hyponatremia means there's too much water in the body, right? So I'll go a few steps down and then come back to this. So normal range we know is 135 to 145. And the symptoms may be very subtle in mild hyponatremia when you're in the range of 125 to 130. You might get some nausea, headaches, lethargy. And in severe hyponatremia, you can have things like seizure, coma, or respiratory arrest. And then chronic hyponatremia might have fewer symptoms as compared to acute hyponatremia. All right, so is anyone here by the name Jack? No one? So we're okay to use Mr. Jack here today? Okay. So what we're talking about is technically this. That this is my Mr. Jack. Okay. And he's a happy guy. He has a input port and an output port. Okay. And to begin with, say he has 4 molecules of sodium and he has 4 molecules of water, okay? So if I have to calculate what's the sodium concentration in Mr. Jack at this time, so we will say number of solutes, which is 4 sodium, divided by 4 of water. So my concentration comes out to be 1 milliequivalent per liter. Make sense? Okay. Now, when I showed you the first slide that what does hyponatremia mean, we said it means too much water, right? So different things could happen now. So first thing I want to think about is if this guy is having a lot of GI losses or renal or extrarenal losses, whatever it is, okay? And when you lose too much of salt, what do you get? The choices are volume depletion or hyponatremia. Right? So we're saying that too little salt in our body is equivalent to volume depletion, right? So say Mr. Jack now starts losing volume, which means he's losing some salt from the body, okay? He's losing some water as well. And then we come and tell the patient or the family member, drink more water because you're having this bad diarrhea, right? So he puts in more water in the system, okay? So what's the end result? That your new sodium concentration would be, you have 2 molecules of sodium now, right? And 1, 2, 3, 4, still 4 molecules of water. So there's relative excess of water as compared to sodium, and your net sodium concentration is now down to 0.5. Does that make sense? So when you have volume depletion, you're losing your salt, you're losing some water, and since you're depleting just with the free water, then that excess of free water in your body is going to cause hyponatremia instead of volume depletion. Clear? Not clear? Okay? All right. So same guy, I'm going to just walk down a little bit. So he was pretty normal. We had 4 of sodium and 4 of water. So when I say someone has hypervolemia or volume expansion, so by definition, the guy has too much sodium in the body. Is that making sense? Right? So if you have volume expansion, meaning too much sodium in the body, okay? There is some increase in total body water as well. And on the same lines, the guy continues to drink free water, right? So he drinks more water. So what will be your new sodium concentration now? So you have 6, my round ones are my sodium molecules. So you have 6 of sodium divided by 8 of water. So what is my new sodium concentration? Anyone with good maths? 0.75, right? So what we're saying that the same Mr. Jack can produce hyponatremia in setting of hypovolemia or hypervolemia because of relative excess of water. It's not making sense, right? I don't see too many happy faces. So one more time, because I cannot move forward till we understand this, okay? So 1 Mr. Jack, 2 Mr. Jack, 3 Mr. Jack. He has an input and an output port, right? In scenario 1, we are normal. So we have 4 of sodium and 4 of water. So our concentration in this example is 1 milligramme per liter, right? In my second example, the amount of sodium is less because the guy is volume depleted. His water content is also less, but there's still relative excess because he's drinking some free water, right? So with this, my new sodium concentration is 2 divided by 3, which is about 0.6. So we are calling this as hypovolemic hyponatremia. Making sense? I see some nods. Yes, now that is good. The third example is that I have hypervolemic guy. So he has too much sodium, more than normal, right? So 6 of sodium. And the guy's water also is up because he is hypervolemic. So there's too much sodium and too much water, right? And he continues to drink free water as well. So my net concentration of sodium is then 6 divided by 8, which is roughly, what was it again? 0.7, right? So you can develop hypovolemic hyponatremia or hypervolemic hyponatremia because it goes around relative excess of water with respect to your sodium content. Good enough? Thumbs up? Good, good. All right. Then we will be talking something about what we call as euvolemic hyponatremia, right? So what we're talking about is the same Mr. Jack, a happy guy, okay? And what the issue now is that he is not able to get rid of free water from the body, okay? So he's not able to get rid of water. So because he's euvolemic, the sodium content has not changed. It's still 4 sodium molecules, okay? The water was normal, but because he's not able to get rid of water, so the relative excess of water in the body, so my new sodium concentration is again 4 divided by 6. So I gave this guy hyponatremia again. And why is he not able to get rid of free water? We'll talk about ADH in a few minutes. But so far, I'm hoping that this whole volume thing is making sense. Good? Okay. Moving forward? Okay. So the second concept that I want to talk about sodium is the concept with serum osmolarity. Okay? So normally if we say the serum osmolarity is dependent on, you don't have to memorize, but just for understanding, the formula is it's 2 times the sodium concentration plus we say BUN divided by 2.7 plus glucose divided by 18. That is how we calculate serum osmolarity because we believe these 3 things contribute to serum osmolarity. Okay? Now, the normal BUN is about 15, okay? And can I round off 2.7 to 3? Okay? And normal glucose is about 100, okay? And I'm going to round off 18 to 20, okay, just to make my calculation easier, and twice the sodium concentration. So this gives me 5 points, 5 points. So we're saying out of a serum osmolarity, which we say normal is closer to 290 milliosms, only 10 points is contributed by BUN and glucose, right? So for the most part of it, my serum osmolarity should be dependent on my sodium concentration. So it should be directly proportional, right? Because we're saying only 5 points are given by glucose, 5 by BUN, which is a very, very like 10 points, versus 280 extra points, which is dependent on my sodium. So by definition, serum osmolarity should be directly proportional to the sodium concentration, okay? Now, if the sodium concentration is low, we would expect serum osmolarity to be high or low? Low, right? And if the sodium concentration is low and my serum osmolarity is normal, would you believe this is true? Yes, no? No, right? So that is what we call a pseudo-hyponatremia, because the sodium concentration is low, but still your serum osmolarity is normal, meaning something else is going on, okay? And when we talk about pseudo-hyponatremia, we say it's a lab error, which is because of high concentration of triglycerides or protein in your serum, which gives a falsely low sodium level. Making sense? Okay? Good? Okay. Guys, if you're understanding it, keep smiling so that I get some visual clues that you're getting it. If you're not understanding, then make a sad face, okay? All right. Okay. Then the third thing I want to talk about is, what if the sodium concentration is low, but the serum osmolarity is high? Is this entity pseudo-hyponatremia, or what is it? Anyone on the left back? Would you call this as pseudo-hyponatremia? If the sodium concentration is low, but the serum osmolarity is high? Anyone on the right half, right back? Just nod your heads. Yeah, we don't call it as pseudo-hyponatremia. We call this entity as translocational hyponatremia, okay? So what is going on, that you have this ICF and ECF, right? At equilibrium, we believe the osmolarity inside should be equivalent to osmolarity outside, so that the water freely moves in and out. Okay? Now, for whatever reason, if I add osmotically active substances in my ECF, such that glucose or your glycine or mannitol, so these are osmotically active substances, right? So they are going to cause higher osmolarity in your ECF, which will raise serum osmolarity, because our formula, which I first showed you, did not talk about these additional substances, except for glucose. We'll come back to it, right? So when the osmolarity is higher in the outside world as compared to inside world, then water will move from inside to outside or outside to inside? Inside to outside, right? So we're saying that water comes from ICF to the outside world, which is very similar to that Mr. Jack who was just living a happy life with a balance. And as soon as this water comes outside, the water molecules go up, and that causes lowering of the sodium. So we're calling this as translocational hyponatremia. Okay? So we're saying one more time, when the water comes out of the ICF to ECF because of osmotically active substances in ECF, we call this entity as translocational hyponatremia, okay? And we know that whenever someone is calling you with a sodium of whatever, 120, 130, 110, we always ask, what is the serum glucose, okay? And glucose is also osmotically active, so we want to correct the sodium for the elevated glucose. And the way we're doing it is by using your MedCalc or Hippocrates. But other way of doing it is that you say your corrected sodium is 1.6 times your glucose minus 100 divided by 100. Okay? And you add it to your current serum sodium so that you can get the corrected sodium. Good enough so far? Questions? Are you loving the new whiteboard idea? Okay. So let's go to the old PowerPoint now. Okay. So far we talked about, Mr. Jack has water intake and water losses and a happy balance. And then either if he has increased water intake or he has decreased water loss, both those things will cause relative water excess, which can cause hyponatremia. We're much more than clear at this point on this, right? Then we're saying that We'll come back to this reasons in a second. We said check serum osmolarity, and we did talk about plasma osmolarity. Normal is 275 to 290. And if the plasma osmolarity is below, if the plasma osmolarity is normal and serum sodium is low, we talked about hyperlipidemia or hyperproteinemia. We already talked about if plasma osmolarity is high and the sodium is low, we're talking about translocational hyponatremia. And then if the plasma osmolarity is low and serum sodium is low, we call this as true hyponatremia. So this slide should make perfect sense by now, right? Smiling? Smiles? Good enough? Okay. All right. Thank you for the smiles. Then, translocational, I hope no questions on this either. We already talked about it, right? And then volume status, right? We kind of talked about the volume status already, so I'm going to review on this PowerPoint thingy again. So best method to evaluate someone's fluid or volume status is to put them in a jar or glass and see how much volume they have. It's a joke, guys. Okay, so we want history, we want physical exam, and we want to look at the labs to assess someone's volume status, right? Okay. So, we already talked about hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic. Makes sense? Now we know how different volume statuses can still give you hyponatremia, right? Okay. Then, hypovolemic hyponatremia, when can it happen? So you have loss of sodium in free water and replaced inappropriately by hypotonic fluids such as water in your bottle. And sodium can be lost with renal losses or extra-renal losses. Renal losses, the biggest one is diuretics. And extra-renal losses are GI losses or excessive sweating, or third spacing of fluids, or cerebral salt wasting. I'm going to keep going just to get more concepts and versus going on the etiology part. Okay. Euvolemic hyponatremia, we already said the sodium was normal. We stayed at 4 molecules, but there was total body excess of body water. And this could happen in patients with psychogenic polydipsia, SIADH, hypothyroidism, or adrenal insufficiency. We're going to talk about all of them in a few more minutes. And then hypervolemic, we said total body sodium is higher and total body water is higher, and you still continue to drink more water. And that's when you get hyponatremic. Could happen in patients with acute or chronic renal failure, congestive heart failure, cirrhosis of liver, or nephrotic syndrome. Okay? But you got the gist of it, why it is happening, right? Okay. So next thing we're going to talk about is urine osmolarity, right? So let's escape this, minimize this. Okay, it doesn't want to minimize. I'm going to go back to this. So we can simply do the PowerPoint as well. I mean, I hope this is helping the writing part, right? Okay. All right. So I want to take a few steps back from wherever we left at PowerPoint. We'll come back to it for a quick review, okay? So let me start with someone with hypovolemic hyponatremia, okay? You know, even before that, I want to touch on, should I touch it now or later? Thinking. Okay, let's start with hypovolemic hyponatremia, okay? So when someone is hypovolemic, so what is happening in the kidneys, right? One, we said hypovolemia means there is too little sodium in the body. So kidney is a smart organ, and you would expect it to do what? To leak more sodium or to hold on to sodium? Hold on to sodium, right? So kidney would try to hold on to sodium, so you would expect urine sodium to be less than 20, right? But if this is being caused by renal losses, for example, someone on diuretics, then obviously your urine sodium will be more. Make sense? There's always a but or an exception in our nephrology world, okay? The second thing is the world of ADH, okay? Where we say that it gets stimulated, one, if you have volume depletion, okay? Two, if you have low blood pressure, which goes hand in hand with volume depletion. 3, if your serum osmolarity is high. And 4, some physiological stimuli, such as someone has nausea or pain. Okay? So what does this ADH does actually is, if you look at the kidney, it became like a heart. I don't know why. That's okay. But you guys know it's a nephron. Okay. So what ADH does is, it goes to this distal collecting tubule and it opens the water channels. We call them as aquaporins. Okay. So once these water channels are open, okay, it's not an active pump. Okay. So all it does is open the door. Okay. And that's when the water moves from the area of this area, medullary interstitium, has very high osmolarity, right? Because of the countercurrent mechanism. So water is pulled in, and whatever urine is then coming out, what do you expect the urine osmolarity to do? Down or up? It's going to go up. Making sense? So the water is flowing through it, and if I pull out water from the urine is going to get more concentrated, which means the urine osmolarity is going to go up. Okay? So in other words, Mr. ADH and then our renin-angiotensin-aldosterone axis, it gets stimulated and it holds on to the sodium, it holds on to the water, and it's helping the body to deal with your hypovolemic part. Okay? Now, when this person develops hyponatremia, right, then we come in the picture and we want to treat this patient not with the bottled water, but with normal saline, because he had too little sodium in the body, right? So we start giving this person normal saline. The next thing is we volume deplete this person, and then his blood pressure normalizes, his volume then becomes normal, then the stimulus to the ADH goes away. Right? As soon as the stimulus to the ADH goes away, all these water channels are closed, and then you have this brisk diuresis. You have suddenly the patient starts putting out more urine, okay? And that's when there's a risk of rapid rise in the sodium. Did it make sense? Not as much, huh? So again, Mr. Jack, he is volume depleted. So instead of having this normal picture, we lost 2 of sodium and we lost 1 of water. Okay? When I came in the picture, I gave this person normal saline, and then his volume is depleted again. So the sodium reappears, this water reappears. So now he's back to his normal volume status. Okay? And remember, this Mr. ADH was making the kidney to hold on too much water. So as soon as that ADH stimulus is gone, the doors are closed, all this excess water kind of comes out of the body. So this water now starts flowing out of the body, and that's when your sodium will start rising rapidly. Okay? Making sense? Okay? So that is why in every single patient with hyponatremia, we want to do frequent labs to see, one, if the sodium is correcting at the right rate of correction. We're going to talk about it soon. And 2, we want to monitor the urine output, because if they're peeing a lot of urine, the chances are the sodium is going to go up very quickly. And then you have a delay from the lab test. You order a stat BMP, which comes back in 4 hours. 6 hours, I don't know. But at least looking at the urine output, you know that you're expecting this to go really up really fast. So you stop your fluids, you fluid restrict that person in anticipation of overcorrection of sodium. Okay? Good enough? Any questions? None? Okay. All right. So this was with the hypovolemic hyponatremia. So treatment is normal saline. You deplete the volume and you monitor the labs closely. Then the second thing is we're talking about hypervolemic hyponatremia, right? So in hypervolemic hyponatremia, it's easy to fix the patient because we know he has too much salt and too much water. So the first thing we tell the patient to do is restrict your PO intake. So we put them on fluid restriction. Good? If that is not helping, the second thing we do is we give them Lasix, because Lasix makes you pee out something which is consistency of half normal saline. So you're peeing out some salt, you're peeing out some water, you're correcting your hypervolemia part, you're getting rid of some water as well, so you're getting rid of the hyponatremia part. So in your hypervolemic hyponatremia, you would restrict their fluid intake, and then you will give them Lasix to treat it. Good enough? Easy peasy? Smiling faces? Good. Okay. Moving on. I don't know how far I can go below, but so far it's like I'm far below. Let's see. Are the people at West Point okay with this? Yeah, I'm talking to the God.
We're good.
Awesome. Okay. All right. So next thing I'm going to talk about is the little flow chart we have read so far. Okay. So someone with hyponatremia. First we said check serum osmolarity. If the serum osmolarity is normal and the sodium is low, we call this entity as pseudo-hyponatremia. I can't write anymore. Pseudo-hyponatremia, right? If the serum osmolarity is low, we are calling these people as hypoosmolar hyponatremia. In other words, this is true hyponatremia, right? And the third thing we said is if serum osmolarity is high, we will call this as translocational, right? We're already done with this part. The second step was we said to check the volume status, right? In the volume status, we said the volume could be, I'm at the end of the page actually, I don't know. Yeah, we said the volume could be low, it could be normal, it could be high. This entity we're calling as hypovolemic hyponatremia. We already talked about it, we're clear on it. If the volume is high, we're calling it as hypervolemic hyponatremia. We talked about how to treat it and we're good at it, right? So the only part we'd have to now talk about is euvolemic hyponatremia, okay? So I'm going to next work on that. So when you think about euvolemic, technically we said that Mr. Jack is someone who has normal sodium content. I don't know where I made it. I'm going to make it here. So he has normal sodium content, but he has too much water. So that's the definition of euvolemic, right? So the next thing you need to look at is urine osmolarity, okay? And the reason it helps is you look at it if it is greater than 100 or less than 100, okay? So if it's greater than 100, by definition, in the world of hyponatremia, we say the ADH is active, okay? So let's go back to our Mr. ADH, right? We said that the stimulus for ADH are volume depletion, right? And right now we're in the middle row of the euvolemic hyponatremia. So we know that volume is not the stimulus for this ADH to be active. Agree, disagree? Agree, right? Secondly, we said the serum osmolarity, if anything, was low in the middle section, right? So that is why your serum osmolarity should not be stimulus for the ADH in this patient, right? So that is why we call this ADH as inappropriate ADH, or in other words, syndrome of inappropriate ADH, which has like 1,000 other causes. But is that making sense? So we do have low serum osmolarity. It is not high to cause ADH stimulus. And we have normal volume status. It is not low to cause ADH stimulus. But our ADH is inappropriately active, so we're calling it as SIADH. Okay? All right. Can I take a quick break to cancel this and open another? I don't know. Don't save or save it. I don't know. Don't save. Now I'm lost. Okay, we're good. All right. So now we're going to talk about SIADH. So we're saying that this is our little nephron and this is our distal collecting tubule, right? And okay. And this is our medullary interstitium. And here is where this ADH is active and it has opened the doors forever. Okay. So in other words, if you imagine we're in this hall and we have 200 people in this hall. Okay. Can they fit? I don't know. 500 people. Okay. And in the corridor, there is nobody. Okay. So when Mr. ADH comes and it opens the door, we would be wanting to go outside, right? On the same lines, if we have 500 people outside in the corridor and we open the door, then people would want to come inside, okay? So this is exactly what ADH is doing. It's opening and closing these doors. This is very, very important to understand, okay? So in the world of SI-ADH, these doors are open forever, okay? And this medullary interstitium, it has high osmolarity forever. Okay, because we have our active sodium potassium 2-chloride pump here, which keeps pumping all these solutes. So this place has osmolarity closer to 1200. So whatever urine is going through, it will have the water go from this direction to the medullary interstitium such that your urine osmolarity will be high. Okay, so you're constantly absorbing more water. So why I brought this up is because when you go by, this is just for you guys to understand what is going on with SIADH, okay? So when you go by the urine volume, so urine volume is dependent on how much solute is in the body divided by the osmolarity. This is a simple formula from your physics, okay? So we're saying this urine osmolarity is very high to begin with, okay? If this is very high, the urine volume will be less. So that means you're able to get rid of less free water and you're in the scenario of persistent hyponatremia, okay? So the two things we tell people to do is, one, we tell Mr. Jack, you know what, your volume is beautiful, but you're holding on to this extra water, so please restrict your free water intake. We fluid restrict almost every single patient we come across, okay? The second thing you guys might have seen us doing is giving them salt tablets or sometimes high protein diet, okay? So what that does is it increases the solute in the body, which will help in increasing the urine volume, meaning get rid of some extra volume from the body. Making sense, okay? And the third thing I want you to understand is if you happen to give someone normal saline, we often say that it's going to worsen their hyponatremia and setting of SIADH. Because what is happening that say the urine osmolarity is around 600 and you give them someone 1 liter of normal saline, which is about 154 milliequivalents of sodium plus 154 milliequivalents of chloride. So you give them 300 MEQs, right? So you give 1 liter of saline to someone, they will pee out how much? Ouch. No, 0.5. Right? 300 divided by 600 is 0.5. So the other half liter stayed in the body, which actually lowered their sodium even more. Okay? So in patients with SIADH, when I'm dealing with severe hyponatremia, I have to give them a fluid which has osmolarity more than their urine osm so that the numerator increases and I have net positive urine volume, which in other words, if I give them 3% saline, which is about 1,026 milliequivalents divided by 600 is the urine osm, right? So they will end up in making closer to 1.3 liter. Is it making sense? No, I lost you guys. I lost a lot of you. I lost you guys, right? Let's take a step back. So we said SIADH, the doors are open forever. So urine osm is fixed around 600 milliosm. Okay? And then I want to increase their urine volume. Okay? So I can do two things. One, I can increase the solute in their body by giving them salt tablets or high protein diet. But in acute setting, I can give them 3% or hypertonic saline, okay? Hypertonic saline has 513 milliequivalents of sodium and 513 milliequivalents of chloride. So my net solute load to this patient would be 1026, right? And then if I give 1 liter of hypertonic saline with the given urine osmolarity of 600, I will make this person pee out how much? 6, 1 to 6, 7, 8, 9, 10, 40, about 1.5 liters, right? So you're trying to get rid of extra water by giving them high solute. Making sense? So that is why in the world of SIADH, we do not give normal saline. If we have to give any sort of fluids, we try to give 3%. Okay? All right. Not that okay still, huh? Questions? Don't hesitate. It's your chance to ask me now. 15 more minutes. Hurry up. Yes. I was going to talk about the next. So diuretics and SIDH, okay? So remember I said that these doors are open forever, right? I have something fun to do here, actually. Maybe this. No, it did not do anything. 1 second. Okay, beautiful. All right. So we said this medullary interstitium is at 1200 milliosms, right? So if and the reason I'm saying this urinosum is 600, because at equilibrium, at the very end, when the urine is about to exit, it should have equilibrated halfway, right? 600, 600, right? So if someone is making very concentrated urine, the way I can make it less concentrated is by asking some people over here to go in other rooms, right? Or in other words, if I close the entry over here. So if I give Lasix to these people, it blocks the sodium-potassium 2-chloride pump here, right? In your ascending loop of Henle. And that's why less sodium, less potassium, less chloride is in your medullary interstitium, right? So technically, I'm dissipating the osmotic gradient here. So it's no more 1200, okay? Okay, so the only way people could come in this hallway was through these steps. Okay, so if I close those steps, then not many people are going to come in. So I'm blocking the sodium-potassium 2-chloride pump here. So not much sodium-potassium 2-chloride is going to medullary interstitium. So my medullary interstitium osmolarity, say, falls from 1200 to 800, for an example. Okay. Now, with this 800, the midpoint will be, when urine is about to exit, half of this is 400, right? So in the same person, when I reduce the urine osmolarity from 600 to 400, it is indirectly proportional, right? So by decreasing the urine osmolarity, the urine volume is going to go up. And the more urine they pee out, the more water they're losing, and that's going to help with the sodium. Good enough? Good? Okay. Questions? Rule of? So potassium, someone with hyponatremia with a sodium of 120, for example, and say their potassium is 3, if we give them, if we supplement the potassium, it's also going to increase their sodium level. But for management per se, we just have to keep in our heads that it might raise the sodium as well. Okay? Good? All right. So before going to the PowerPoint, one other thing I want to talk about is acute versus chronic hyponatremia. Okay? So we call hyponatremias chronic in about 48 hours. Okay? So what is happening is that this is your intracellular fluid, this is your extracellular. And at baseline, there's a nice balance, okay? So whatever thing that causes your sodium to drop will make your serum osmolarity to go down, right? And with that, the fluid will move from the outer world to the inner world. Make sense? Okay? So it will cause some swelling in your brain cells, and the patient will have some headache, some nausea, some changes in mental status, confusion, obtundation, coma, whatever we talked about, okay? So to help out, inside the brain, we have something we call as organic osmoles, all right? And I call these organic osmoles as very old people who take their own time to walk out of the brain cells in the outer world. Okay, so they take about 48 hours to go outside in the outer world. Okay, so when the organic osmoles reach the outer world, they help somewhat with this decreased serum osmolarity such that now there is less swelling and edema around the brain, and hence we say the chronic hyponatremia patients are not as symptomatic. Okay, so in the new balance, what we did now is we have raised the serum osmolarity tiny bit, by adding organic osmoles to it, okay? So this patient now comes to the ER with a sodium of 110. We get consulted, we give this person lots of fluids, and the sodium, say, goes up to 130 in 12 hours. Okay, so now let's see what's happening. As soon as we increase the sodium concentration, it's going to increase the serum osmolarity as well, right? We already know that. Organic osmoles were already in the outside world. So overall osmolarity is now much, much higher, okay? And the fluid will go from the area of low osmolarity to high osmolarity. So this fluid will go from ICF to the ECF world, which will cause shrinkage of these cells and what we call as osmotic demyelination syndrome, okay? So that is why we have to be very, very, very careful about rate of correction of sodium. And if someone, we don't know the duration of sodium, how long it has been low, we take it for granted as chronic hyponatremia, okay? Anything more than 48 hours, if it's low, we call it chronic hyponatremia. And then we follow the rules of, in first 24 hours, try to raise the sodium by 4 to 6 milliequivalent per liter, okay? In first 24 hours with a maximum of 9. Please do not exceed 9, okay? And in 48 hours, the max is 18. All right. And if we happen to overcorrect someone, so someone with sodium of 110, my goal would have been, shout it out. Don't be so serious. Come on, guys. 110 plus 6. Thank you. So my goal would have been 116, max of 119. And say if I was already at 130, then I need to bring the sodium down, and I can give it by consulting nephrology, right? Or in other words, we give them some D5 water, and if they're making too much urine, we actually give them DDAVP to slow them down so that they pee out less water, and that way we are helping in or preventing rapid correction of sodium. Make sense? Good? All right.
So the indication for the administration of the whole urine, that's not going to do with how much we overcorrect the sodium?
Yes. Yes. So what normally happens is if you have a glass of water and say half is water and you have 2 teaspoons of salt in this, for an example, okay? And say I have a little leak valve which is able to let only water come out, not the salt. Okay? In that case, my sodium concentration is going to go up. Make sense? Okay? So what DDAVP does is it puts a stopper on this valve. Okay? Because now it's making your kidney to hold on to every single bit of water because we've given supraphysiological concentrations, okay? So once we do that, say your sodium was rapidly rising, okay? As soon as I put this valve in, the stopper on the valve, the sodium concentration would tend to plateau, okay? Now if I add more water to this, as in D5 water, it's going to make my sodium to go down, okay? If I add more salt in this, it's going to make my sodium to go up. Okay? But if someone is not polyuric to begin with or not making enough urine, say someone is at 15 mLs per hour, even if you put the valve, it was not making much difference. So it's not it may not help, and it may harm you if someone has pulmonary edema or someone with psychogenic polydipsia, because in those cases, you want them to pee out. Right? Did that answer your question? Okay. We usually go by anything above 150 an hour. And we keep DDAVP ready on the bedside, especially in ICU setting with severe hyponatremia. Yeah. And I'm not touching on a lot of parts here just because it's more of a management issue at fellows level. So I'm not touching there. But just for you guys to understand. Questions so far? No? Everybody's happy? Okay. So that was the part with my writing stuff. Now let's see where we are. We can skip that, but I think it just helps in putting things in context of what we just talked about, okay? Because when I'm writing, I'm just talking in whatever direction. Okay. So first step was serum osm were good, volume status were good. Third was urine osmolarity. And we said the world of ADH, we already talked about that. What are the, yeah, what are the stimulus for the ADH? We said, we already talked about this, right? The volume depletion and increased serum osmolarity. And we said ADH could be appropriate or inappropriate, right? And we already talked about if urine osm is greater than 100, then we're talking about ADH is there, okay? And then we judge about appropriateness based on the volume status. All right, the next step was checking the urine sodium. We said if it's less than 20, then it could be true volume depletion, or in patients with effective arterial volume depletion, as in patients with heart failure or cirrhosis. And then what I forgot to mention was in patients with SIADH, your urine sodium has to be more than 40, okay? And I say this because it's a state of euvolemia. So we're talking about that patient's volume status is just perfect. So kidney should have no stimulus to hold on to the sodium. And if anything, when you are retaining all that extra water, then it does cause release of your atrial natriuretic peptide, which goes to your kidney and it makes it leak more sodium in the urine, okay? So if you're dealing with a patient of hyponatremia and the urine sodium is, say, 25 or 30, we just call it as indeterminate. We cannot call it as SIDH unless it's more than 40. The problem is if there are renal losses causing volume depletion where your urine sodium will be high, or in patients with SIDH where urine sodium is high, then it's harder to distinguish unless you do a good exam. Good? Okay. And then renal salt wasting is the same thing as cerebral salt wasting, where you also have the features of volume depletion, and then you're losing lots of sodium in the body. Then SIDH, these are the causes. You can review it. I'm not going to read them out to you. And then three features of SIDH. We said euvolemic, urine osm more than 100, because that means ADH is active, and urine sodium more than 40. And serum uric acid is usually low at less than 4. And in these patients, you should also check a TSH and a random cortisol to rule out hypothyroidism or adrenal insufficiency. Okay? Because those two also have very similar clinical scenario. All right. Rate of correction, we already kind of touched on this as well. I'm not going to repeat it. We're good, right? Good, good, good? Okay. And then relower serum sodium with hypotonic fluids of rapid rise, we already talked about it. And then use DDAVP in special circumstances, we talked about it. And then we talked about hypovolemic hyponatremia, where you should do the fluid replacement with normal saline, and then make sure you monitor it to prevent rapid overcorrection. And the hypervolemia, we talked about water restriction and treat with diuretics, so nothing new here. And then with SIDH, we talked about water restriction with high salt, high protein diet. We talked about loop diuretics, right? When to use that? Shut that door, the one coming down from the steps. So shut down the sodium potassium 2-chloride pump by using your Lasix. And then demeclocycline is in the long run, and we don't use it as much these days. And then acute SIDH, we're saying water restriction and hypertonic saline. So we've kind of touched on that as well. Good? Is it making it more confusing to go back and forth?
I don't think so. I think when I was an intern, you came and you put everything together on once, like you wrote that down. I don't know if you have like 2 or 3 minutes, and I remember I like that.
Sure, we can definitely.
Just, like,
yeah.
Serum,
yeah,
like,
I can do that.
Just like 2 minutes, so if people want that.
Yes, that's a great idea. Okay, perfect. So bottom line, take-home message in bad handwriting, okay? So you have hyponatremia. Then the next thing is we said check serum osmolarity. We said if it is normal, we are not worried. We're calling it as pseudo-hyponatremia, right? If the serum osmolarity is low, we're calling it as true hypoosmolar hyponatremia. If your serum osmolarity is high, that means an osmotically active substance is present, and we're calling this as translocational hyponatremia. We're happy over here? So in the patients with true hypoosmolar hyponatremia, we check their volume status, and we're saying the volume, three things could happen. It could be low, it could be normal, or it could be high. If it is low, the next thing we're looking at is urine osm, which we know is going to be more than 100 because this is appropriate ADH activation. And then you look at the urine sodium. If the urine sodium is less than 20, we believe this is extra-renal losses. If it is more than 20, we think it is renal losses. It's not writing. I don't know why. Yeah, I have no idea. Okay. Then if so this part is clear, and you treat these guys with normal saline and you monitor their sodium so that we don't overcorrect. Good? In the patients with hypervolemic hyponatremia, again, the ADH will be active because this is reduced effective arterial blood volume. So your urine osm will be higher than 100. Your urine sodium will be less than 20 because the kidney is sensing that there's not much volume in the body. And because of that, urine sodium will be less than 20. So if you see, you cannot distinguish hypovolemic hyponatremia from hypervolemic hyponatremia because in both those cases, the urine osm and urine sodium is about the same. And what is going to help you is your physical exam and history. Okay? And in these people also, we do fluid restriction. And we treat them with Lasix so that they can get rid of some salt and some free water, and we correct their volume and we correct their sodium.
And usually these are your
Cirrhotics, heart failures, yes. Nephrotic syndrome, yes. And in your euvolemic hyponatremia, we are checking the urine osm, and it could be more than 100, which we said is most likely SIDH, especially if your urine sodium is more than 40. Okay, and the other things to rule out is to rule out hypothyroidism and to rule out adrenal insufficiency. Okay, and then one thing we did not touch was if urine osm is less than 100. So what do you do with these people? So these are the people, we put them in the category of beer potomania or in the patients with psychogenic polydipsia. So they are the people who drink tons of water and they pee out tons of water. So because their volume is just fine and there's no inappropriate ADH, so urine osm stays less than 100. Okay? And in these people, the problem is when they do binge drinking, that's what drops their sodium acutely. Okay? And we talked about treatment of SIDH with fluid restriction, and then we said salt tablets, high protein diet. In acute setting, we said hypertonic saline. And in these people, we just fluid restrict them and tell them to have more solute in the diet. So that is, I can't fit in one page, but questions? Good? All right. We don't have any more time. Okay. I'm like, all right. Thank you.